Hi, everyone. So thank you all for joining. This is a webinar from the Global Observatory of Long-Term Care. Specifically, this is the second webinar from the Quasi-Experimental Methods Special Interest Group. Adelina Comas-Herrera is the director of the observatory, but unfortunately, she isn't able to attend today. My name is Naz, and I work as a research coordinator at the GOLTC, and I'll be doing a quick introduction for the observatory. To begin with, the GOLTC is an initiative of the International Long-Term Care Policy Network, and the idea behind the observatory is to harness the collaboration that many of us had through LTC COVID and now focus on tackling wider long-term care challenges. And so the aims of the platform are for cross-national learning, so to identify key shared challenges and showcase how different countries and localities are addressing them, and to share evidence and facilitate collaboration. And this is an area that's open to anyone interested in long-term care, including policymakers, industry, advocates, care professionals, and academics, etc. So this is a new initiative, and if you would like to engage, you can become a member here. I'll be sharing links in the chat during the webinar, as there are many ways to engage with the observatory, including sharing publications, country profiles, and joining special interest groups. The key to engaging with the observatory is to become a member first, and then you can have access to all of those things, and it is free. In terms of our next events, we have a webinar from the Pain and Care Homes Interest Group on the 17th of September. And then there will be more later on in the fall, but I'll pass it over to Javiera now to share her screen.
Okay, so just very briefly, so I'm one of the coordinators of the Quasi-Experimental Method Interest Group, which is part of the Global Observatory of Long-Term Care. And we have been also organizing webinars. This is our second webinar. Just to give you a bit of a background or what are the interests of this interest group. First, it is to bring together academic policymakers and practitioners that they have an interest on knowing what works in terms of long-term care, particularly long-term care policies and intervention. This cluster is strongly methodological, as is a quasi-experimental group, so we are trying to look at causal effect, but we also believe that everyone can learn, everyone can understand better the methods that are out there, and in that sense, we are trying to be very inclusive and become a platform for knowledge exchange and also to able to explain complicated or complex ideas in simple words. So everyone is welcome. And this is just a steering group. Bram, who is in the Erasmus University of Nottingham. We have Joaquin, who is in the Department of Social Policy at LSE, and myself, who is at the Care Policy and Evaluation Center at CPEC. And just we have been growing. I just said this is our second webinar, and the first webinar there were around 20 members, and we had expertise from 13 countries at that point, and now we are double the number of members. We are 42, which is very good. The issue at the moment is that we only seems to attract academics and researchers. So if you know any policymaker or practitioner, or if you are in the call and you are one of them, please encourage any colleagues to also join. As I said, we are very inclusive. And to do that, you need to go to the website, the Global Observatory of Long-Term Care, go to interest group. It's a very simple form and you can join. You can also add your expertise and your profile. So that's all from me. And now over to Catia Nicodemo, who is an associate professor at the University of Oxford and also at the University of Verona. So over to you, Catia.
Thank you for the invitation and to be in this group. So this is a paper that is joined with Manuel Serrano Alarcón, Elena Guillermo and me, that they are in UPF, and Manuel is in the Center for the European Center in Italy. So in this paper, what we try to do, and we are trying to do our best, is to measure something related that if when we're talking about long-term care, this is better the long-term care more institutional one, or this is better, for example, using the more informal one, so the home-based long-term care. So we try to see if these two type of long-term care service make difference in the patient's health outcomes. So as we know, I don't know if this is should go, but it doesn't go. We hope it will go away soon. So as we know that there is this global aging population in many countries, and especially in Europe, for example, if we think country like Italy, Spain, UK, or France, for example, we have a huge problem related to the population became older and older, and this is also require more and more long-term care service, and this long-term care service seems that, of course, are quite expensive, and they have huge implications also for workforce, and all this is a cost for the healthcare system. So don't know if I can move this a little bit, maybe on the top. So the motivation of this paper is the fact that there are many of people, especially old people, and during the last year of life, there is this huge decline in physical and mental health. And so many of old people, if you ask if they prefer to go, for example, nursing home to remain home, of course, they decide that they would like to stay at home. Why? Because this is due to familiarity and comfort that you have at home, but also because especially we know from the literature that especially for people with certain kind of disease like dementia or kind of anxiety, depression, having the same rule and having the same setting is really important. So moving these people from one side to another side could be a major life change that could have also negative impact on health. So of course, so there is arguments that remain at home could be better, could be have some positive aspect for these patients. There is also some arguments in favor of nursing home, because it seems that nursing home you have more people that are professional, and these people that are professional usually tend to take care of the people in a way that maybe they are less risk in, for example, dehydration or type of foods and this kind of thing. So of course, there is this idea that the nursing home could control many aspects of residents that live there. Of course, there are, for example, these better backs and holes that they tell that if you have a loss of autonomy, identity, when you enter in this total institution of nursing home, and this is could reduce the quality of life. So for this reason, I think should we stay or should we put the long-term care in a way that it's more institutional, or we can also push for a home-based? Of course, this is something that we try to disentangle in this paper, but of course there are still some limitations that we can see later. So in our paper, we measure how the long-term care setting, home care versus nursing home, home-based care here, we should say, impact healthcare utilization. And particularly, we look at two types of healthcare utilization: the hospital admissions, so elective and emergency, and these hospital avoidable condition, like, for example, if you have a wound or these kind of things. The effect of care utilization could be shed some light on the relative effectiveness of each type of care. So if you have, if you observe, for example, that patients that are in a certain setting, like for example, nursing home, use less hospital admission or less hospital avoidable condition, we can see that okay, nursing home probably is better than the stay at home with more informal care. And so this is the main hypothesis that we look after this research question. Spanish long-term care system is quite good in that way to measure this, because the long-term care benefits that you receive, it is the patients or the claimants or the people in the family people that they can decide what type of care they want. So you can choose the type of care. So although you are very, for example, huge, sick and highly dependently, you can still stay at home if your family wants so. So it is a system that you can really decide what you can want for you for the long-term care service. Of course, this is different, for example, other system where it is more, the choice is not so open. So I think this system is quite good, because here the choice is free, and so it is easy to measure these decisions. So our hypothesis, if that we have in mind, is that if care setting does not differential affect outcome, this is validate that patients and maybe the family take the right decisions that can stay at home or they can go to nursing home. So, of course, this is inform a lot the policy makers, especially for the fact that many people require long-term care service, and usually long-term care services are quite expensive. So understand this type of model, and if the family and patients can make the same decision that can be done by a provider, in a way, this is could really help the policymaker to have the most effective and efficient system. So our paper is related to other study. First of all, a study that analyzes the effect or the impact of long-term care on healthcare utilization and healthcare outcome. So we have Barrett, Gupta, Bax, and also another paper that we have published in Journal Health Economics 2 years ago, where we look again with the same data if the long-term care service have an impact on healthcare utilization. And we found, for example, in this paper that the long-term care reduce emergency admissions, increase the more planned elective admissions, and also increase the visits in primary care. So this is could be quite a good reason to have the long-term care system implemented in a country. And this is in line with the rest of the papers that go in the same direction when they look at the long-term care impact and the healthcare outcomes. There are a few studies that really look at the effectiveness type of care, and this is due to limitation in the data access. There is some from Korea, and there is also the Netherlands data that they compare nursing home versus formal home care. So there is no informal versus formal care at the moment that they try to disentangle these. And so our paper really contribute in these few studies that you can find. We have a lot of other studies that look at the relation between formal and informal care, but more in aggregate way, and also some of them also for Spain, that where they try to look at the finding a complementarity between the two care options. So for sure, our paper will bring some more evidence in the literature. So the contribution here, first of all, we compare nursing home and home-based long-term care. We put inside this equation the family caregiver, as this has not been done in previous work. And we also stratify the care by needs level and not just by eligibility criteria thresholds. And of course, this will help to understand if we should go with more like centralized decision makers or leave to the patients to take the decisions. For the people that are not familiar with the Spanish long-term care system, in 2007, Spain implemented the long-term care system across all the region. So the law is at a national level, but each region needed to decide the amount of money and the benefits that they can want to allocate to the people and so on. So they give, as I said before, a great degree of care choice and flexibility. There is this eligibility criteria based on a questionnaire where you have many questions that look at your daily activity, and they can give you a score at the end of that, and you receive, or you are eligible to receive benefits if your score is 25 and above. And so the benefits that they can choose are: this is nursing home, formal home care, or cash or informal caregiver. So the cash for informal caregiver is given if you have some family that look after for you, or you have also, for example, some person that you can hire and you can give money to look after. So this is a kind of really home care based. All type of care are available at all level of long-term care needs, so there is no restriction. Restrictions are about that. So, for example, if you have a very low score between 25th and 30, for example, you can still choose a nursing home, and instead, if you have very high score, so very dependent person, you can still decide to stay at home. Of course, the benefits depend, its mean test depend on the income of the claimant. So if you have any question, please stop me, because I cannot see that. Can also have a discussion later, but if there is anything, please stop me. So the data that we have here is a sample of more than 180,000 individuals that are entitled to to receive these long-term care benefits. We look at the region of Catalonia. Is the only region at the moment that we have possibility to look at administrative data. And we have data from 2009, 2014 of all the people that have applied. So not just the people that are receive the long-term care benefits, but also people that could apply and they don't receive any benefits. So we look at this is more or less 30% of long-term claim population and are representative for the Catalonia region. Sorry, we linked all of this is individual with the hospitalization records 3 years and before and after the period that we observe. And so we have the data from 2007-2017 about the healthcare utilization in terms of hospitalization. We use 3 subsample with people with a similar long-term care needs. So we have a moderate level of long-term care needs. So the ones that have a score between 50 and 60. We have a moderate plus, the ones between 64 and 74, and we have the one between 75 and 85 that are the several level of long-term care needs. Now, of course, there are we have excluded people below 50 and the people above 85 for several reasons. First of all, people below 50, they still they have applied so this is grade 1, but they still not receive money during this period because due to restriction in terms of economic crisis, and the above the 85, so people that are here, there is a huge attrition because these people are really sick and usually they die very quickly. So for this reason, we concentrate in these three chunk of grades and needs that are very, and they are entitled and they're receiving the long-term care needs. And so if we categorize individual based on long-term setting, so nursing home and home-based care, we can, for the three subsample that we have, we can have disease that many of people, of course, decide to use informal care versus nursing home. And of course, people that are sicker, usually they use more nursing home than home care. But well, in terms of respect to the other two subsample, but of course we can see that many people that are in the top of this distribution, they still use home-based care. So nearly 70% of them, they still use home-based care. So many of them, of course, use informal care, and the formal care at home is very tiny, but it still have some of them that they decide to have this is more formal care at home. So the empirical strategy. Yes, Brenda.
Thank you. I just wanted to clarify about the definitions or who comes up with the scoring. I'm not familiar with it. So is it subjective? So could there be somebody just on the borderline of the thresholds between, or are you going to talk about that anyway? Just checking.
Yeah, that it could be that this is so if we can see me here, so it could be that they are very close to the thresholds, so they can jumping on the other grade. For example, if you take a grade 1, it's quite a big grade. But if you take, for example, 75, if you have 76, automatically you're jumping in the other grades. But we use the score and not the grades because, of course, this is the difference, I think, respect to the other ones, because, of course, this is, we can use this continuing estimation of needs instead to have just the thresholds in per se. So I don't know if there is any other question. No. So the empirical strategy here, the idea is carry out this definitive model where we compare the nursing home versus home base and see if there is difference in the hospitalization. So our main questions is the probability to be hospitalized in ERT. We have done this also monthly, and we have our main important variable. This is this dummy variable equal 1 if the individual receive a nursing home, or if and 0 if they use the home care. We have, of course, this time fixed effects, and we control for a bunch of characteristics of the patients and so on. So we set a baseline of 2 years before the long-term care benefits. So this is K. This is just 2 years before and 3 years after that the claim come in and the application come in and the benefit come in. So when we look at the difference in mean of nursing home and home care, we can see that there are some difference, but are very, very tiny. And especially, of course, people that are single usually or if they have a huge, a more high score of long-term care, and they tend to go more nursing home than home care. But the difference also, there are some of them significant. They really seems that there is no huge difference among the patients that decide to go in a home care versus nursing home. So if we look at the probability of hospitalizations for example, sample 1, that it's the moderate long-term care, we can, if we so look at this probability, this is just the probability here, we don't use yet the comparison, we can see that there is no huge difference on the hospitalization for nursing home and home care. So if we set up just at 2 here before receiving the benefit, we don't have a huge difference between these two people. If we look at emergency hospitalization, seems that there are at the beginning a little bit difference, and any elective hospitalization seems that home care have used more than nursing home. We don't find any difference, for example, in any kind of avoidable hospitalizations. And this is very similar for all the groups, so all the subsample. So this is a moderate plus that are very similar to the ones that we see before, and this is are the severe long-term care needs. Again, we don't see a difference here between the two groups in the probability to use a healthcare service utilization before and after receiving the benefit. If we look at the diff and diff here, so the estimations between the nursing home and home care, where nursing home is our treatment group and the home care is the claimants or the patients that use a home care. We again, we seems that there is, for example, if we look at the elective, seems that it's nearly 0. The same for kind of avoidable hospitalization. There is a little bit of difference that we can observe on any type of hospitalizations, but very tiny and non-significant. And the same happen for any emergency hospitalization. Again, this is especially for the severe groups that where we expect a little bit more difference, but for the rest of the group, this is quite nearly to 0. So we don't observe huge difference if you are at home or you are at nursing home. And we control here for all these kind of characteristic, age, gender, and so long-term care score needs, and income, everything's on the demographic characteristic that we have, plus region and so municipality and so on. So how we explain this? What we look seems that there is a health shock at the 0. So if we look at this monthly data, seems that, and this is, we have done, I just presented this for emergency hospitalization subsample 1, but it is for all the sample and all the type of hospitalization. Seems that there is a shocks and health shocks at the beginning before they ask for long-term care needs. So this is could explained by the fact that there is a shocks, and so this shock is the same for home care that for nursing home, that arrive at the time just before to ask for long-term care. And so this shock that are higher in emergency hospitalization could explain part of our results. And we can see, for example, also looking at the diagnosis that can explain this kind of spike in hospitalization prior to the entitlement to receive the LT, the long-term care benefit. When we look at the diagnosis that could driven this spike, we see that this is usually driven by injury and fracture and by mental health diagnosis, especially the one with dementia and the delirium, that could make these shocks at the beginning. And these shocks at the beginning can explain why, for example, the people decide also to go nursing home or home care. And so this is what we observe. So if we look at again the diff and diff, so taking considerations also the effects on other conditions, we again don't find any difference that we can report here. So what we have done, so we have extend our results and look at the heterogeneity, looking, for example, a difference by gender, a difference by cognitive impairment. So we take all different diagnoses. I don't report all of them, but we can have this in the paper, and we don't find really difference between nursing home and home care, for example, by female or male, or by different cognitive impairment, or by different effects on injury and fall. So there is no anything that apparently could explain a difference between people and these head shocks that they have just before to enter in the long-term care conditions. We have done also robustness checks looking at mortality, because of course there is a huge attrition, especially for the severe group here. So we observe that usually the one that you choose in nursing home have an increased mortality from year 1. But if we look at up to 3 years, we don't find difference between the two groups. We also say, okay, maybe there is some difference in characteristic between the groups and between the so the nursing home and the home care, especially for the severe one. So we have used this propensity score matching combined with the diff and diff, so that we take all the people with the same characteristic, and so we can combine them for the needs that they have and the group that they are, for example, moderate, severe, moderate plus, and we can see if they still have a difference there. And so we can, when we combine the propensity score matching and with the DDD, and we cannot really find any difference here. So results are very similar to what we found before. So no effects on any hospitalization. There is some pre-trend in emergency hospitalization, and there is this reduction in emergency hospitalization after a year of treatment. So more or less what we observe here, for example, this is related to mortality. It seems that the mortality increase a little bit, especially after 1 year for any hospitalization, but the mortality decrease. And if we look at the propensity score matching plus the diff and diff results, again, we find some difference, especially in any hospitalizations, but not significant. But the rest seems that there are no really huge difference, or no difference at all between the nursing home and the home care groups when we look at the emergency hospitalization, elective, or this avoidable hospitalization. So in summary, what we find in these papers that there is no significant difference in avoidable hospitalization between care setting there is some drop in emergency hospitalization for nursing home. Of course, so we didn't stress too much because was already studied in the previous papers. Of course, we know that long-term care reduce the healthcare utilization, especially the emergency one, but it seems that this is drop is slight higher for nursing home, especially in long-term care. There is, for nursing home, seems that there is this spike that could explain part in emergency admission, that could explain why sometimes we find that, especially for people with injuries like fracture or dementia, these people usually are more setting in nursing home, and this could be used for also for policymakers. Maybe certain type of patients could be or need to be more attended in nursing home because there are this kind of type of disease that could require certain type of service. There is also an anticipation health shocks that could influence so this care setting choice. We don't find a really huge difference between informal and formal care. So our discussion here seems that, okay, maybe when we look at having this free choice on long-term care in Spain could be something suitable for populations, and this could be useful for policymakers because this country can really, patients can make the decision. Seems that the decision are appropriate decision here. Now, of course, it's also true that we need to take in consideration that Spain is a country with strongly family ties that look after these old people, and also there is a strong primary care system that also are make that if there is no nursing home, there is someone that look after them. So this is something that we need to consider when also we cannot apply this to all the country because of course are not the same. So I think consider the fact that Spain has this condition make that the decision, leave the decision to patients to decide which one is the better long-term care service that they need, probably is the most appropriate one. And I think I stop here because I think 20 minutes has done.
Ripala, I don't know if you would like to take over or do you want me to?
Yes, so I'm happy to. So yes, thank you for a brilliant presentation. And I think that we have a question in the chat. So
yeah, Kirkos asking if there is any unexpected results in the data. What do you mean, any unexpected results by data? Sorry, Kirkos. If you related to the fact that we didn't expect the nursing home that we can find these results, or the data, you means the well, of course, the administrative data are always quite complicated to clean and to do, but we didn't find any unexpected issue with the data. And about the results, I think it is something that we expect in a country like Spain, that we can see that they take care a lot of old people at home, so it doesn't surprise too much us. Yes, Brenda?
Thanks again. Thanks, that was really interesting and very easy to follow, so thank you. So actually it's nice to be here. I'm actually I work in Australia, University of Queensland, but visiting University of Galway, Ireland, where I'm from. So this is great. I can actually join because previously I had to do look at the recorded sessions. So I suppose I've written down my question. Sorry, it's here. Just for clarification, first of all, and then I have a question for clarification. So the eligibility is based on needs. So it doesn't matter about their financial situation, if that's correct.
No,
Is that
yeah, it is based on the needs. So they give you money on the score where you are. Of course, it's the income. Usually, they have three big thresholds of income. One is a very low income at 18,000, 80,000, 100, and above 100. So it's only three big chunk of income that they discriminated. But the people above 100,000 euro with income are very few in this database. Yeah.
okay? So a question then is about the supply of care. Were you able to model in the number of providers in the local areas, or because this all reflects demand, I guess?
Yeah.
But what if they had no choice? They had to have home care because there wasn't formal institutional care available. That's just one idea in terms of the supply side.
Yeah, no, this is a good question, and we are aware about that. Of course, supply of a nursing home is really important, because if you have more supply, probably you use more. It is true that the beds in nursing home are not so many, and so of course you need to go in this waiting list. If we unfortunately we don't have data on a nursing home at the moment in terms of number of beds or where they are located, to also take in account the supply sides. It is, of course, this does invalidate our results, because our results tell us, okay, we still observe that people in nursing homes versus people that stay at home, they can have the same level of use of healthcare here. What would be important to, because everyone can choose nursing home, so it's not depend because it's really severe or not severe, so you have a priority in the nursing home. It is just you go there and you put in the list, and they don't in nursing home they don't discriminate by really priority, so it is based on when you first arrive, first service. And so this is make the fact that, of course, having the supply side here, maybe if you increase the supply for nursing home, we can see that less home care is utilized. It is possible, and probably I will expect that. It's also true that there is some push by the governments now to go more versus home-based than more this is nursing home.
Thank you.
Thank you.
I think there was another comment put in the chat, but you addressed that.
Yeah, there is no choice. I agree that the problem is that okay, no choice, but you need to use informal care. But what we want to say here that using informal care, using nursing home, really there is no huge difference. Now, should we provide more informal, more formal care and less informal care? This is another questions that of course have many implications, because of course nursing home could really help, for example, family to take care of these people, but at the same time it could be also require more resource and more resource in the system, and so this is a trade-off that sometimes it's not easy to solve. Yeah.
Javiera. Thank you.
Hi, Katia. Thank you for the
Yeah.
presentation. I have a question about so combining propensity score matching, because I am a bit, let's say, surprised that it didn't create a difference, in the sense that people that do go to nursing care are probably not very well, and therefore I was surprised that you didn't find any difference. So I was wondering about what variables were used in the propensity score matching? Because I was expecting to see a difference when you added.
Yeah, no, it's a good question, Javier. So we do the same, because people say, oh, maybe the people that decide to go to nursing home maybe are a little bit selected, in the sense that they are single, they don't have daughters, or that can look after, or they cannot find an informal caregiver, so these kind of things. And so we say, okay, maybe let's see if really we can take the people with the same set, so people that are both single, both the same age, both that live in the same area, and so on and so on, and see if these two are really different in terms of them. We still did not find them. So there is some issue related to the fact that maybe the choice it is not in the sense that maybe people that wanted to go in nursing home are people that are a little bit selected because they are in a situation that could be push them. But it is also true that in Spain, everyone can apply for nursing home, so there is no a list of prioritization there. Like, for example, when you have education and children in a school. And so for this reason, I think we don't find this huge difference when we use the diff and the propensity score matching.
Now, I was going to ask about the data. So you are using Catalonia, and I was wondering, because you said that you don't have more data, but kind of maybe we will have more data in the future. So I was wondering whether you are expecting to get more, if there will be any perhaps regional analysis done.
Yeah, we are there is another they call community region in Spain that have this data, and but not so they have not linked with the hospital admissions, so we cannot compare at the moment different region how they behave, because of course it is true that in Spain is a regional level, so maybe some region push more for some type of service than others. So at the moment we are not able. What we are doing at the moment in Catalonia, because Catalonia has moved this integrated care, so the nursing home visits now has been done by primary care. So we try to evaluate that, and probably will also give us more information about the nursing home and what they do in the nursing home, what they have done so far in nursing home. This information was not available until now, and so maybe we can complete these results in the future, thinking and go in direction what Brenna is saying, that what is the supply here and what they are doing. Maybe we don't know too much about quality of nursing home, for example, who are the people that are there and so on. So maybe these people in nursing home are very low skilled, the same that of caregivers that you have at home. And so for this reason, we don't find this huge difference and so on. So I think it would be quite interesting to see what's up, and now that the primary care has been integrated with nursing home in Catalonia.
There was a question put in the chat asking if the paper is available.
The people, yeah, if you can send me an email, I'm happy to send to you. Is under review at the moment. It's so we should submit in a couple of days. I just wait for this seminar to take comments. But please send me an email. I'm happy to share confidential the paper.
I do have one thought that came to mind when we were covering this, and I was just thinking about cultural differences and actually some stigma that can be associated with making use of nursing homes. So I think for different cultures, people will very much be interested in what the quality is like of nursing homes. But even if there is a good quality residential care facility available, I think in some cultures or some areas, people would be hesitant to use it because they fear that they might be judged by other members of their family or neighbors. So I was just wondering what the situation with that is like in Spain. Is that not the case, or
Yeah,
is it
well,
variable?
it is very family based until I think the first generation now probably has changed a little bit and they use more and more the nursing home, but especially I think in the areas that are more rural areas and in some areas that are not big city or so on. There is this culture that you have all parents, and all parents usually stay with the son and these kind of things and look after them. So there is something that it's also true that this has changed a lot in the last few years. I think in Spain, this is still probably not true in Italy, especially in south of Italy, because I can see that there is a still stigma attached, as you say, about nursing home, and bring parents in the nursing home maybe can be judged by neighborhoods that this is not the right things to do. So, but in Spain, I think has changed quite a lot in the last few years. But yeah, but still a family tradition, and this could explain also. And also, Spain has received a lot of wave of immigrants from South America. That I think this has helped also to integrate a lot the caregiver in the market, and they speak the same language and so on and so on. So this has helped a lot to building up more formal care than formal care.
Yes, actually, now that you brought it up, yes, I recall other people have mentioned to me as well that they think that the situation is changing and it's becoming more acceptable to make use of formal care services.
Yeah.
The last very important thing to do is to thank you for a brilliant presentation.
Thank you very much for inviting me. It was a pleasure, and thank you for all your comments. Thank you.
Yeah.
So
Thank
we
you.
keep in
Yeah,
touch.
that was
Thank you.
very insightful. Yeah.
Thank you.